I'm Adele Framer, and I'm the president of Psychotropic Deprescribing Council. Welcome. The Psychotropic Deprescribing Council is a new organization, and it was founded to bring clinicians, patients, and other interested parties together in a community of concern having to do with the deprescribing and the tapering of psychiatric drugs and also other psychotropics such as pain drugs, because there are people who are going off of these drugs have common issues. The objective of the Psychotropic Deprescribing Council is to do research and education of clinicians and other interested parties, families and patients, and to enhance medical and professional training. So we intend to gather our knowledge together and communicate that to the wider medical community in the hopes of improving patient care and outcomes, because we know that when people have a difficulty going off of these drugs, it can really upset their lives and basically end up in poor medical outcomes. So our slogan is safer practices and better outcomes. And I just want to thank everybody for coming today. So this particular roundtable is to explore the roles of psychotherapists and other people who are formally trained in psychotherapy, and to explore their roles in the deprescribing process. So we know that people are coming to you who might have been on a psychotropic for a number of years and may be considering coming off, or you may see them in withdrawal and they may not know about it, or they may be very concerned about it. When you first start speaking, please introduce yourself and your interest in deprescribing. So I want to introduce myself. I'm I guess you could say I'm a long-term patient advocate. I founded a website called survivingantidepressants.org, and I've been writing about and publishing about psychiatric drug withdrawal syndrome for quite a while. Karen Hoffman is our board secretary. Sherry Underland is our treasurer, so we are the members of the board. And I want to also introduce Angela Peacock, who is a military veteran. She was a principal figure in the film Medicating Normal, a really excellent film, and she has extensive field experience as a psych drug withdrawal coach. She has an MSW, and she concentrated in clinical mental health. So she has a perspective as both a lived experience and as a coach and having had that educational background. And Guy is a psychotherapist from the UK. She's active in the Beyond Pills All Party Parliamentary Group, which is a formally convened study group in the Parliament, and she's active in other groups. She's author of the Guidance for Psychological Therapists, Enabling Conversations with Clients Taking or Withdrawing from Psychiatric Drugs. This is a guide for therapists, and she is creating a curriculum to train therapists in the UK that might be of interest in the United States. Anne has a few PowerPoint slides to show to get the conversation started. So she'll do that now, and then we'll go into a more general discussion.
All right.
I think we were going to start with Angie. Yeah.
So I'll just talk for a couple minutes just so that you kind of know who I am and my background. I had lived experience of deprescribing from over 40 psych drugs in a 13-year period. I had a very horrific withdrawal experience. It's become my life's work now to help others because of what I went through. I did get formal training as a therapist at Washington University in St. Louis as a master's in social work. I also minored in social policy to learn about programs and program evaluation and advocacy and all that stuff. So then after being in the film Medicating Normal, I kind of quit doing film screenings and started coaching people full time. So in about 3 years, I've seen about 1,500 clients, either in groups or individually. And I work with, I would say, like a little bit different population than you maybe. And I'll tell you the reason why I decided to shift to coaching instead of therapy. I basically work with about 7 different groups of people. People that are just contemplating tapering. They're not sure. They just need a little hand holding. They need to find good information. They might need me to advocate with their doctors or therapists. People that are currently tapering. People that are in acute withdrawal for one reason or another. Either they completed a taper or they were cold turkeyed from somebody in the medical system. Protracted people. So people that are over 2 years off and trying to get their lives back after a pretty hard withdrawal experience. I work with people that are parents of people on meds, some with serious mental illness diagnosis, some that are trying to just do harm reduction principles underneath doctor's care. Also people with psychosis and other serious mental illness diagnoses. And then I do professional consultations, CE presentations, and business coaching with people that want to do this work. And like, how do I set that up? And how do I do that ethically? And what did you do, Angie? I need a little help, that kind of thing. So I do also have a couple coaches on my team that I've just brought on. So it's kind of like, until we can get therapists on board, we're trying to like fill that gap in between, which is why we need you and what we want to hear from you and how you work on that. But we look at ourselves as kind of like informed peers. We do have clinical background, we do have formal training, but we also had lived experience. And the value of that is that a lot of people we work with, they want to know our experience. That helps them, that validates them, that reassures them that, okay, you're a person that you have, this happened to you also. You're not just knowing this from like a theoretical perspective. It's extremely valuable. We also have people that they don't want notes taken. They don't want the threat of 911. They want to be able to talk about suicide openly because suicidal ideation can be a part of the withdrawal experience for many people, regardless of their history. So that's kind of what we do. We also run peer support groups. The peer and mutual support is so crucial because they want to know other people are going through this and that we're all kind of getting through this together. So I have I think we're at like 30 groups a month that meet twice a month at least. So I have a very full practice. I need help. We all need help. And we are hoping that we can, through PDC, somehow develop some kind of formal training, some CE presentation to help you do this more ethically, because I think, I mean, this is a controversial topic, as we all know, but I think as we continue in the next 5 to 10 years, it's going to be more and more of an issue. The awareness on social media is bigger than ever. People sharing their experience on YouTube, organizations popping up, people popping up that are doing this work. So that's all I have to say. Thank you for being here.
Thanks, Angie. And I think that just goes to show it's just such a wide area of work, and there is an awful lot of really good work happening in different fields, really. And I think, we were talking a little bit earlier about, we've got withdrawal coaching, we've got peer support, we've got therapy, and there's all sorts of flavors and mixtures of those things going on. I work more in what I've come to call withdrawal informed therapy. So my entry into this area, if you like, is more that I've always been interested in how the medical model, the idea of how distress arises, how that intersects the practice of psychotherapy, and obviously how doctors talk about distress, the practice of diagnosing, of prescribing drugs, and how it's described to clients or patients, depending on what you call them, as to what's going on with them, as to why they then might choose to take the drug. So I'm coming at it very much from sort of that angle, and have been instrumental. So I was the lead editor of the guidance for therapists rather than the sole author. I wouldn't claim credit for all of that. So we kind of got the best team of people we could get together in the UK to write this guidance, because we recognised that a lot of therapists in the UK, and I think this is certainly true from my discussions with Angie, have been explicitly told you shouldn't be having these conversations with your clients. And that the therapy organisations, the bodies who accredit people in the UK, needed to give explicit permission to therapists to say it's okay for you to be having these conversations, because we're having the conversations anyway. The clients are asking us questions all the time, but actually having explicit permission that it's okay to educate yourself on this and to have these conversations. But here are the lines over which you need to be careful, because everyone's scared about saying something they shouldn't say, or being criticised, or being put back in their box, I'm afraid largely by medical professionals, that we needed to give that explicit permission. So that's why we put together the guidance in the UK. And we kind of recognised, I was just going to give a very, very brief, only 2 or 3 slides, just a brief idea of the kind of different levels of engagement that we sort of recognised that psychological therapists might have with this topic. And it's up to every therapist to decide for themselves what that level of engagement is for themselves, what's the right level, and how far they make any interventions with any client is always subject to the general frame of the therapy. It's always subject to the interests of the client. So I'm just going to share a couple of slides. It helps if I actually press the share button, doesn't it? So here we go. So hopefully you guys can see that. So just these very broad levels of engagement. Well, first of all, just understanding what our own beliefs are about psychiatric drugs and educating ourselves on the evidence, just becoming aware of it. And until I read Robert Whittaker's book, Anatomy of an Epidemic, I knew nothing. And I'm really I felt quite a lot of shame, actually, the fact that I didn't know anything. The next kind of level is being able to listen for our clients' experiences and beliefs about drugs, and to start to be able to just explore those beliefs with them. Being aware of the possibility of withdrawal and feeling able to flag it. And I'm guessing that, most of you, because you're here today, you're already well into this. So, a lot of this is obvious, but there's a lot that should just be an automatic part of the training for therapists. That's my belief, in these kind of earlier levels of engagement that hasn't been to date. Information sharing about how drugs work, their possible effects, and information sharing about how to withdraw safely. And last, the sort of deepest level of engagement is being actually able to support a client through withdrawal, offering withdrawal-informed therapy after the worst is over. Now, that's not about giving medical advice. We make the distinction in the guidance between offering information and offering advice. And it's absolutely fine to offer information from reputable sources. What we don't do is offer personal medical advice about specific doses or drugs or that kind of thing. And when I'm speaking, just assume you see a UK sign above my head, because it's all based on what the kind of normal practice in the UK. So those are the sort of broad levels of engagement. And then there are these specific opportunities within the therapy relationship that we've identified to support clients. And the first one is supporting the informed consent process. And just to be clear, certainly in the UK, there are 2 informed consent processes. There's the one that happens inside the doctor-patient relationship around the original prescribing. And then there's the informed consent process within therapy. And we can support the doctor-patient one. We can have conversations with clients about, well, what were you told by the doctor? How did you react to that? What did you think of it? Did you get enough information? But we're responsible for the informed consent process in therapy. So how can psychiatric drugs impact the process of therapy? That's our responsibility, to actually have that conversation with our clients. Second opportunity is around exploring clients' understanding of what they think's wrong with them, as opposed to perhaps what's happened to them. Signposting information about drugs, as I've already mentioned, as distinct from giving advice. Exploring clients' experience of drug effects on themselves, on therapy, on others around them, on their relationships. And that's when both taking and or withdrawing. And then the last opportunity is actually to support a client through withdrawal and afterwards, though we would always say that a client needs to find a knowledgeable prescriber in order to support that process as well. Clearly, actually finding a knowledgeable prescriber is sometimes harder to do than it should be. Now, we've created quite a lot of training materials around this guidance, and all of those training materials, there's lots of recorded videos of the authors of the guidance talking it through. And they're all available on the website that's listed on the bottom of the slide, so prescribeddrug.info. If you go to the training tab, click under the training, all of these videos are there. So Dr. James Davies, Professor Joanna Moncrief, you may know some of these names. There are some of the people who are specialised in each of the different counselling modalities, so person-centred, psychodynamic, CBTs, the main therapies used in the UK. We have a representative from each of those modalities doing a bit in the section on practice. Some from Professor John Reed and others around what do we actually know about withdrawal. And then there's a whole load around, well, how do we actually put this in practice? What does that mean when we're working with our clients? So that's a very whistle-stop tour through just roughly what the UK guidance covers. And I hope that's of interest.
Thanks, Anne, and thank you also, Angie. So now we're going to start the open discussion, and I'd like to suggest that we definitely want you to talk, and some of the questions that we would like to hear you speak to are, how do your clients express their interest in going off of their psychotropics? How can this become a productive avenue for psychotherapy? And what would you like to have in training and in practice to deal with deprescribing? So please, does anybody want to speak?
I just like to say hello, everybody. I'm Marcello Maviglia. I'm a psychiatrist. Please don't kick me out now that I said that. But Kelly, Adele, I'm so glad to see you, and in person on video.
Thanks, Marcello.
Can I say something about the legal stuff? I mean, this is probably one of the hills we have to climb. I had a lawyer look at our stuff too, and even these consent agreements, in some states, it doesn't matter what your consent agreement is, they can sue you anyway. That's one thing. Secondly, how do I say this? I've lost a few to suicide. Okay, that's happened. But my relationship with the family was such that they knew it wasn't me. Do you know what I'm saying? So I really think the relationships are important and trying to engage the whole family. But I also hear you, and I almost don't want to say this out loud because it's kind of disgusts me the way that we have to try to avoid the landmines. But recently I formed a new antipsychotic support group. And when I did that, the reason I did that was because the antipsychotic guys were in with the antidepressant people. And it's just like a different flavor. It's a different issue. It's a little bit different. Some of them had strange behaviors or whatever, and it was like affecting the SSRI taper people. And I was like, I got to separate these groups. Okay. So when I wrote that language for the antipsychotic support, I did put it in there. Like, it's mandatory that you have to be working with someone, that you have full control over your taper with a provider. Because I just have concerns about that. Like, I think all of us, like as a whole, you have to be careful, because even just presenting information, can sound to someone that's suggestible or vulnerable, like, oh, I want to go do that, and without all the information. And then it could be construed as like you coerced them to do that, or you suggested that without them having all the information, because we can't control that. Like if I put a video up on YouTube, somebody watches 5 minutes of it, I'm not teaching them how to taper, and they go take that and do something. I can't control that. Okay. So I did consult, like when I started doing this, I consulted with David Cohen at UCLA, and I told him, like, I don't know what to do. And he's like, you need to put everywhere that you are not giving therapy. You are not consulting, you're not doing, it's a non-medical, you're support only, resources, education, to try to cover your butt as much as you can. But he's like, if it push came to shove and something happened, then I would come and testify on your behalf. I mean, I don't know what else to do. It's a hill. Like, I feel like if that's what we have to die on, then that's what I have to die on. I have to do something ethically. I don't feel right just walking away with my life. Like, I'm not wired that way. So I don't know the answer, Kelly. And I've had lawyers look at all my stuff, and we did the best we could. And now just kind of like hope it's going to be okay. I don't.
Yeah, I think this is a concern that when you are a client is contacting you and you recognize the problem, but the doctor doesn't recognize the problem. Anne, you have something, your hand is up?
Yeah, do you want to finish speaking, Adele? It was just
no.
sort of...
Yeah, so I was going to say, like what solutions do we have for this? Now, the PDC is going to be talking to prescribers also. So we're hoping to be able to connect an informed prescriber community with everybody else. So, but that's going to, that's going to take some time. So yeah, Anne, please.
I think I just wanted to say something about the whole notion of risk. And it's a debate that is happening in the UK because psychotherapy is not a regulated profession in the UK, which I personally think is the right thing, because I don't think regulation provides any more guarantees about necessarily the idea that a client is safe with a practitioner, because we all know plenty of cases where people have been fully licensed and accredited and regulated and have still been bad actors, if you like, in terms of abusing clients in some shape or form. The practice of psychotherapy is a risky practice anyway. We are risking ourselves in relationship with our clients. We are talking with very, very vulnerable people all of the time. It's the nature of what we do. And we are talking and listening to thoughts and all sorts of urges around taking one's life. It's a commonplace part of what we do. But I guess the big factor that I hear the concern, particularly from our colleagues in the States, is around the idea about being sued, about having been perceived to give medical advice about drugs. So, and I understand that if a client does take their own life, then maybe there is most risk of that suit happening. Interestingly, in the UK, we've got a lot of press at the moment because one of the members of our royal family, a sort of a minor royal, did actually take his life after being prescribed an SSRI and withdrawing from it. And interestingly, the debate is around recognising that we need to provide better support for patients. It's very much centering on what are the things that we should be doing better here, rather than who's to blame, rather than looking at the doctor, what were they doing? It's kind of recognising it's a systemic issue. And I don't know whether it's in the UK, we're just better at recognising that it's a systemic issue and not to blame the individual practitioner. But I appreciate we're working culturally in very different environments.
Well, I think one of the differences in the U.S. is that the practitioners are rather separated from each other. I think that there's more of interaction among practitioners in the UK. It's just a closer community, and you also have the centralized authorities. So you have something to at least you have something to debate about. So if you get certain types of directives, then the say the therapist community can talk about it. But in the United States, we don't really have any forums for that.
We had to create those, though.
Yeah.
Yeah.
Yeah. I think that Mad in America provides a forum for it to some extent, but there are many more people, many more mental health professionals who don't know about Mad in America than know about Mad in America. Are there anybody else have any want to contribute any experiences? I'm particularly interested in how are people. You probably have clients who are maybe not aware that their psychiatric drugs are causing them problems, but you become aware of it. Does anybody have any experience with that?
I have experience with that. I'm a nurse on an inpatient psychiatric setting, and I was trained that, mental illness is caused by chemical imbalances that are fixed by medications. And so that was my practice for years, and that's what our doctors told us. And I worked there for years and years and years before I ever heard of protracted withdrawal. It was because of Robert Whitaker's book that I started to go down that rabbit trail. But I can say that in the establishment mental health system in the States, that there is just an incredible lack of awareness about it, that people who do this full time every day have no idea that protracted withdrawal is even a thing. And so once it was on my radar, I started to see it everywhere. But I'm also, only a nurse. I'm not a prescriber, and those scope of practice concerns and those legal concerns are very intimidating. Mm-hmm. Nurses, therapists, we don't generate revenue for hospitals. Doctors and psychiatrists, they do generate revenue, and most doctors in the States are working for corporations with $1 million legal teams. They're going to guard their doctors. They will gladly throw a nurse or a therapist or anybody like that under the bus if it protects them from liability. So that's very intimidating for trying to fight the good fight.
Right. Do you find yourself in the position of wanting to advocate for patients, but having to be very, very careful about it?
Oh, absolutely. Yeah, because, doctors do not like to hear from nurses or have their judgment questioned from nurses or therapists or even their own peers.
Yeah.
So,
good.
Does someone have? Oh, thank you.
That Marcello, I am basically intervening very gingerly. Part of it because I am a psychiatrist and people don't know me, and I don't know if it's going to be any strong reaction. So I have to admit that anytime I attend, a group that deals with withdrawals, I'm always trying to be humble and see if I can talk. So that's the way I'm presenting myself. So I ask you for your permission. Could I intervene very briefly, respond to some of the issues that you raised? Is that a yes?
Okay. Yeah, absolutely.
Okay. So just briefly, I started a clinic for a track in a clinic for withdrawal from psychiatric medications within a substance abuse clinic, a dual diagnosis clinic. This was planned. I'm an addiction specialist, So besides being a psychiatrist, because I felt that the best environment to do this was in a recovery-oriented milieu where you have people that really believe that you can get off medications. And I find that the recovery-based approach and the peer support specialists, which I work with daily, are really supportive of me. So I found the right support right there. I couldn't find the same support within the Department of Psychiatry. I'm speaking from actually the Center for Native American Health here in New Mexico. Mad in Italy is deceiving. I'm Italian and also part of Mad in Italy. Okay, so I have a complex professional life, but what I understood in terms of shaping a support mechanism, a support network, I understood that I really needed to find it in the recovery field. And so it's been now 20 years that I've been working with peer specialists. And I have to say, I am honored to say that I've been supervised and I continue to be supervised by peer specialists. So I'll stop right there. This was just a little bit of feedback there in terms of developing a support network.
Right. So, David, you're in a general psychiatric unit, is that right? An inpatient psychiatric unit?
Correct. Yeah, like an acute hospital setting.
Mm-hmm. Do
When
you have
I-
peer
Oh,
you have specialists there?
Sorry, what was that, Adele?
Do you have peer support specialists there?
They do have people in that role, but it's also, it's also a very short stay type setting. The lengths of stay are on average 5 days for adults, so it's usually not a place to even begin tapering.
Right.
So
yes, it's for initiation of the drugs, isn't it?
yeah, it's people get med changes there a lot of the time, but yeah, it's not really a place where tapering is discussed or an appropriate environment for tapering. Actually, what Kelly talked about, an almost residential facility with on an organic farm, that's been what people around here have been talking about too. Like that would be just an absolutely ideal place to get people started, where they're in an environment like that, and they're with peers, and they're able to kind of crowdsource that support and that problem solving in a safe environment where they've got a connection to nature and all that sort of thing. Like that really sounds like the future to me. That's what I would love to see popping up all over the country, along with better education for people like me and people like the doctors I work with, because there's a wild amount of ignorance out there on this issue. I mean, like I said, I worked in that environment for years and years and years, and nobody had heard of protracted withdrawal or anything like that. So I see a need for a change in nursing education, doctor education, and would love to see some residential facilities like Kelly talked about pop up all over the place.
Yeah, I think that having medicine becoming truly more patient-centered is really the ideal. Thank you. Dora?
Thank you. Hi there. My name's Dora. I'm a consultant clinical psychologist in the UK, but also someone with some very deep lived experience of withdrawal and still currently going through withdrawal. So I come with two hats on. And I guess I was just listening to various things that people were talking about and feeling. I do a lot of clinical supervision in my work, and a lot of it is about holding risk and how we hold risk as clinicians. Worked for 20 years in the NHS, our National Health Service here. And just thinking about some of those dilemmas about the risks of being sued and so on. And I think part of it, I suppose I'm speaking both as someone with lived experience and as a clinician, is about how we hold risk in safe ways. And feeling that I'm wondering about how how kind of peer supervision networks could be really crucial and vital, where there's a sort of safe place to bring clinical dilemmas, irrespective of where people are working, to help navigate that. Because as someone with lived experience, so much that has been so profoundly helpful to me has been being able to be incredibly honest in my own therapy, and to feel like that isn't going to be reacted to, because that's actually keeps me safer in the long run. And so I think there's a huge power in that. And I think it would be incredible to have residential resources that people could connect with. But I think the reality is that many thousands of people won't be able to access that for different reasons. And so thinking alongside that of really robust ways of supporting people to stay in the community, to stay at home, because I think that can be so powerful for healing. So yeah, just a couple of thoughts there. I suppose that's why, so finishing that's why one of the reasons for being here is being really interested in thinking about the ways in which peer support could be amplified amongst professionals to support the learning and the education. I was trained in critical approaches to psychiatric care. I thought I knew a lot about it. I still found myself in this position, and it's been such a profoundly deep learning curve in terms of understanding the nature of withdrawal. And I think you can learn that in training courses, and that's absolutely essential. And Anne's training course that's developed here is incredibly powerful. And then the learning goes alongside as well. It needs to happen sort of in practice in an ongoing way, and thinking about ways in which that could be created to fit around people's practice would be incredibly.
Right. How did you become aware of the, I guess, magnitude of the problem?
For myself, or in the world?
When it sounds like you as Ann Guy said, that initially you had one set of assumptions, but then you learned more. You changed them. So what was that? How did that happen for you?
I guess I feel like my story is a little bit, I don't know whether it's unusual or not, but I trained actually with John Reed and with some incredibly critical psychologists. So I was really aware. I remember writing in my doctoral training, I wrote an essay on the dangers of the pharmaceutical industry. I really thought I knew it. And then I found myself in acute distress. I burnt out from being a therapist, and was a mother of young children, and so kind of reached for help, and felt like I would take the risk and take medication. And then it was a much deeper learning that had to happen for me, and my journey has been a very extreme one. But actually, even coming from quite a critical background, I had no concept of the nature of withdrawal itself, and that came very slowly so here I'm not talking as a clinician, I'm talking as someone with lived experience, was this small trickling way of finding things, looking on Instagram, putting in a hashtag, stumbling upon things, that someone else telling me about something else. It was a really like snowbally type thing. I stumbled on Anne and their team's guidance. So I think there's not a lot of, I don't know if it's the same in the US, but not a lot of top down. When I trained 20 years ago, but there's not a lot of top down training where you get like the fundamentals of things. I knew a little bit about the operations of medication, but nothing to the extent of what I know now. And it has been so essential that I've been taken seriously along the way. I've been fortunate in that because I'm a professional, I've been kind of listened to and taken seriously by doctors, because I've been able to articulate some of the extremities of my experiences. But I know that's not the case for many, many people. So actually having my authority alongside starting to know the words to use, like akathisia, for example, was something that came a lot later.
Okay, thank you. Wendy?
Hi, it's such a pleasure to be here. I'm really touched. My employer's here, my therapist is here, my best friend is here. It makes me feel really loved. I'm both a therapist and also somebody with lived experience. And I just want to push into this conversation around risk. Like, I know that people are worried about being sued, but the conversation in itself is a very painful one if you have lived experience, because it makes you feel like you're a risk, like you're a person who did something wrong. When if we look up through, how change in systems has to happen, the risks that are being taken are way upstream. Those are the risks. So I almost want to turn this on its head around risk, and that we're activists, we're advocates. That's part of the work, is to step into risk. I also was trying to think of risk as kind of as a continuum, and there's very little risk in validation. And when I was going through this, I would say that my point that I stabilized is when I believed my story. And so if you can do one thing with low risk, and if you can convince others in powerful positions to do one thing, it would be to believe people. So I think that's it. Thank you.
Thanks, Wendy.
Two quick things. One thing, just speaking to Debbie, your experience, that we're hoping that in the UK we will be putting out there via the NHS some resources for primary care prescribers to actually help people deprescribe more safely from antidepressants. And they are tools based on the Maudsley deprescribing guidelines, and it's very specific resources. And we've got a lot of volunteers amongst some of the local NHS organisations to do this. So we're hoping very much to have better actual real health services for deprescribing very soon. But I think in the meantime, I was just noticing what you're saying about how important the Royal College of Psychiatrists leaflet Stopping Antidepressants is and has in the UK. And I guess I'm wondering, and I was thinking particularly, listening to what you were saying, David, about your experience and how hard it is to be heard amongst your colleagues. And that's one of the things that has been very powerful about the Royal College of Psychiatrists leaflet, is that anybody can print that out and take that to a doctor, to a therapist, to a prescriber of any kind and say, look, here is the Royal College of Psychiatrists saying that you have to deprescribe slowly from antidepressants, and giving some examples. I mean, Mark Horowitz helped write the leaflet, so it's based on hyperbolic tapering, and it's been a real game changer in the UK to have that, because it means that, because we know that a lot of people's voices, if you've been prescribed psychiatric drugs, you've got the chances of being heard and being listened to are sadly reduced, and it just increases the chance of being heard. And I wonder if, and this is a question perhaps, to Adele and Angie, is there any equivalent organisation in the United States that if they had a leaflet of this kind, that it would give that kind of credibility? And I understand they just may be a non-starter and it's just not possible, but that little thing, it's actually been the entire ball game in terms of it becoming more mainstream in the UK. Now, it took a lot to get there, but I'm just wondering if there was one organisation to target in the US, which
That's
would it
the
be?
APA. It would be the APA, who every year I read the conference leaflet, and there's nothing, not even mentioning in the slightest way about deprescribing, not one presentation.
I don't think the APA would go near this, but it seems as though I believe it's called the American Association of Child Psychiatrists is sort of tiptoeing towards the idea of deprescribing for children. I'm thinking, though, that the American Academy of or American Association of Family Physicians might be perhaps the best, the most likely publisher of that type of advice, because I think that American psychiatry is pretty well fortressed up. If the psychiatrists who are here, please tell me that I'm wrong, but I think they're fairly impervious to disturbance of their model. Yes,
I
nobody.
can speak to that a little bit because I have several friends who are doing psychiatric nurse practitioner schooling, and some of them are done, and so they're trained to be prescribers of psychotropic medications. And in their schooling, they did not learn about hyperbolic tapering. They learned about acute withdrawal. They did not learn about protracted withdrawal, and now they're out there in practice. So, yes, I think the system is pretty shored up.
Yes. Okay. So, yeah. So,
I was gonna
Marcello.
that's a really, Marcello, please.
I was gonna say something. I mean, I have been trying I've been trying to do this in Albuquerque, New Mexico now for 6 years, and I distributed that leaflet that you were mentioning, Anne, and didn't make a dent. Actually, it was perceived as something foreign to the American culture, so actually it was counterproductive. Okay, and we get into sort of the politics here, also the prescribing. I suggested all the literature. I read almost all the literature in these 5 years on the topic. Joanna Moncrief, your name, Adele, has been mentioned, and the links, Mark, and on, the bragging book, and so on. I didn't make a dent. The only positive feedback, and I would say the only attention that I got, was from the people in recovery. And I don't mean just from alcohol and substance abuse, recovery, period. People who believe in mobilizing their own natural skills to get better, and that they know that life is not just about symptoms or diagnosis, but it's much bigger. And I have to say, that was for me enough to start this experiment in a clinic which is in the metro area that caters to the underserved.
Mm-hmm.
And I would say, Adele, I find constantly, to respond to one of your questions, I find constantly the need to tell people about the risks of psychiatric medication, because I see people who have an issue with opioids. They come to me, and when I do a thorough history, what I discover is that some of the withdrawal is due to opioids, but there is a substantial hub of symptoms that are due to withdrawal from antidepressant, benzodiazepine, and psychotropics, which gets really ignored because of the way we assess people.
Mm-hmm.
And so when I tell people at the clinic that we need to be thorough in that phase, and I am done, sorry, I'm very passionate about this because it's really important. Then having people in recovery around me, the peer specialists, then I feel like there is hope because they relate to the issue. Oh, thank you for giving me the chance to.
Yeah, thank you, Marcello. I think you're right that the one of the major problems with the drug-oriented paradigm is that it doesn't include a recovery model, and we're breaking it just by saying that people can recover. So which seems very obvious, I think, to everyone here, but it is contrary to the paradigm. And I think that's a really important point. Now, I just want to say that there seems to be an interest here in going, I'm saying, going up some levels in the authority ladder to achieve change. And I would like to invite anyone who really wants to work on that to contact me, because I want to form project groups for exactly that sort of thing. So if we want to, let's say, talk to the American Academy of Family Physicians to recruit them to the recovery model and deprescribing, we'll need to work on that. That could be a fairly long-term plan, but we can, I firmly believe that in unity there's strength, and we can do that if people work together. So I'm just wanted to put in there a plug for what we're up to here. But I want to hear from Angie. I think you had your hand up first. Please, please talk.
Really quick. I was just thinking, because we're talking about systems change, and this is the conclusion that I've kind of come to a little bit. One thing is I did a lot of film screenings with Medicaid Normal with like groups of therapists, or groups of students that were in therapy programs. And then I've talked to lots of doctors. I hear all the stories from all the clients and what they tell their doctor and what the doctor says back. So I have all this collective like points of view. And the conclusion I've kind of drawn is that system change is extremely slow, including legislative change. I did a fellowship on Capitol Hill and tried to present this to congressmen about VA with military United States veterans and the suicide rate and how high it is. And is that due to the increase in prescriptions and our access to healthcare? And when I was talking about it, it was like, it wasn't my messaging. It was like, they're not ready to hear this. Do you know what I'm saying? So if we look at this like cultural phenomenon where more and more people are going on social media and talking about their negative experiences, and this whole grassroots community has formed with our own services, I think it's in our best interest to professionalize deprescribing, coaching, and therapy itself outside of the system, because we cannot wait on the system to do it. I just don't see that happening. Okay. Mm-hmm. I don't. So I've also seen where I recently did a presentation in Kentucky with David Healy and a therapist who is a surviving spouse of someone that we lost to the whole problem. And in that room, I heard over and over again, out of 150 therapists or addiction people, they said, the system I work in, I can't even talk about this. My hands are tied. If I talk about this, I'm being fired. So I think private practice, if you can, the best case scenario, pair up with a doctor who understands this. To me, that's step one. If you want to continue working in this and you want some level of risk management or whatever, kind of what Wendy said, I try not to think about the risk. Like, I did what I can and I have to let it go. And I just know that this is inherently risky, but I'm still have to do it. So I don't know. That's my point of view.
I think that I'm thinking along the same lines. One of the mottos I live by, I learned from a political comedian that we had here in the Bay Area. And he used to close his shows and say, if you don't like the news, make some of your own. And I think that asking the authority figures to change, that's one avenue of change, but it's water dripping on rocks. It's going to take eons. Another is to just do it ourselves, like that's what PDC is for, is to bring people who are like-minded together. And I don't consider this an underground network. I think that this is a legitimate healthcare movement. So that is what we're going out as. We are a legitimate, patient-centered movement, and we are going to propose methods and training that are more patient-centered. That's exactly what we're up to. We're not asking the establishment to do that because they just don't want to do it. So let's do it ourselves. So I believe that we probably can bring enough people together to do this. And I'm really hoping that there's really wonderful people have spoken, and I hope that we can work together. It looks like we might be running over. We were going to close at 10:30.
Sorry. Yes. Gosh.
Is it okay for everybody if we go on a little longer? Okay. All right. Okay. So I think, Anne, you had your hand up.
I think it's Stephen. Stephen has it.
No, I was
Okay.
applauding Debbie.
Stephen.
Okay, I'm gonna
Oh.
open the conversation. Are there any other mental health professionals who want to speak? Okay.
Stephen, you don't want to talk, Stephen?
Yeah, no, I'm going to open.
No.
I'm going to open up the conversation to everybody now, and so, Stefan, please do talk.
Well,
Are you-
thank you. No, I'm here. So first of all, I just want to say it is so cool to see this forum going on, organized by Adele. I am not a therapist. I'm not a psychiatrist. I am a fellow survivor. So I have lived experience, and maybe one of the reasons I'm still alive today is thanks to Adele, who helped intervene when things just got horribly wrong for me early last year. I'm doing a lot better now. I happen to be I'm a serial entrepreneur, tech entrepreneur. So my brain is always thinking of systems and scaling and how to make big change. But while I've been in this very slow recovery, I happen to be sitting on a foundation board. And I thought, what could I do to help start spreading the word? And Adele and I got together and brainstormed a little. And our family foundation ended up giving some seed capital for Adele to start this Deprescription Council. So I'm very excited that there's some structure coming together and that there's the beginning of some scalability. And I think that spreading the word among the professionals so that there's best practices and how to get the word out there is one really critical aspect. And I think, speaking to the theme of how do you get the word up to the powers that be, I couldn't help but think of a parallel recently, actually at our last foundation board meeting, when I was trying to explain to my fellow board members who are supporting Adele how to make them understand the size and scope of the problem we're dealing with, because this is as big a health issue as smoking was. And I had to go back to ChatGPT to ask a whole bunch of questions to understand the size and scope of smoking. And I was very succinctly reminded by ChatGPT that in 1950, 50% of all US adults were smokers, and everyone knew it was healthy. It was good for your lungs. And it wasn't until the early 1950s that some scientific journals started publishing the link between lung cancer and smoking. And it seems obvious to us, but it wasn't obvious back then. And once those links were publicized, nothing much changed. Some people started to sue, but the pharmaceutical industry had all the legal protections they needed. There was so many legal protections that exist in the market to prevent these lawsuits from actually winning, that nothing much changed. But there was still publicity built up around it during the 50s until the mid 60s, when finally the US Surgeon General spoke up and said, hey, smoking causes cancer. And so at that point, there was still, instead of 50% of smokers, it was down to 42%. But that started to give teeth to the lawsuits. A lot of lawsuits started to build up then, several hundred, and they weren't necessarily winning, but they were actually starting to make a little bit more noise. And again, the lawsuits weren't making the pharmaceutical companies too scared, but there was a lot of publicity around it. And it kept building and building and building until the 1990 settlement, where 47 US state attorney generals sued Big Tobacco. You guys probably remember this. And there was a $200+ billion settlement and a promise to no longer advertise to young people. The idea there was to stop filling the top of the funnel with the kids. Mm-hmm. And that brought smoking down by 50%. Took 40 years to get it down to 50%. And it's taken another 30, 40 years until 2022 to bring it down from 50% down to 11%. So another 20, 30 years to half it again. So that gives you an idea of that was for me to explain to people the size and scope and time frame it's taken for this to happen. Now I have a little more hope now because one thing has fundamentally changed in the last 50, 60 years, and that's social media. That's a game changer. And so while I'm sitting here thinking, you guys are out there helping people right now who are ill. And by the way, I'm 50. Most of us seem like we're no longer teenagers here. The funnel's still filling, and teenagers are coming out the other end looking like us and sounding like us. So there's got to be a two-pronged approach. One is how to help everybody now who are us getting off the stuff. How do we slow down the filling of the funnel so that we have a chance? Because people are signing up and getting prescribed this stuff faster than we can possibly stop it. So, I can't help but think, okay, how do we think a little bit outside the box beyond this, which is how do we spread the word among younger people so that we can get them on TikTok to spread the word, to get the attention of the Attorney General, right? So there's got to be a two-pronged approach, the helping and coaching and supporting, and us engaging as well with all of the teenagers and 20-somethings who are getting prescribed and who are already getting into trouble and who want to get off. And I think the more we can engage with that another cohort, the better the chance the word will spread faster on social media. And it's just a question of creating a tsunami of noise. The lawsuits we're not going to win right now. I've gone down this path myself. I've tried to go working with Wisner Baum, who used to be Wisner, whatever they're called, Headland, who have done these big lawsuits, but they basically said it's too expensive. There's too many state protections. It's a fool's errand going down this road. But if we make the noise and we get to the point where you get an attorney general saying something as well, that'll start to give more teeth to the lawsuits. Then you start to create that next wave where the attorney generals will step up. So I'm excited because it's going to happen. And this is a first step. And, I'm just putting my thinking cap on how we can attack this other angle. So Adele, I look forward to speaking with you more to figure out how do we spread the word more to stop the filling of the funnel.
Yeah.
Thank you for listening to my TED Talk.
No, I agree that the supply of people to deprescribe is pretty near infinite. So, so my hope is that if we can educate doctors about deprescribing, which includes tapering is necessary for psychotropics, that they will, that informs them better about the risk benefits of prescribing. So we have a political problem in that prescribed psychotropics are protected by that prescription. So to break the medical model, we have to oppose medicine. It's not, prohibition, alcohol and tobacco were not prescribed. So that became, the crusaders could talk about them being more harmful than doing good, but we're going to have a hard time making that argument right now with medicine. But we can nibble at the edges and undermine the paradigm to bring in a better concept of risk, drug risk. And I think that the model of the OxyContin case is instructive because OxyContin was portrayed as having very, no risk of dependency or addiction, and yet it be like all opiates, it behaved just like an opiate. And though the Purdue Pharma and the rest of the pharmaceutical industry resisted exposure of that problem for quite a while, eventually it did come out. So I agree with you, Stefan. There could be a two-pronged approach. I don't think we can attack medicine too directly. So one of the projects that we've been planning is a video testimonial series for social media, where people say, I wish my doctor knew more about deprescribing and tapering of my drug, because this would be people who had difficulty coming off so that I think indirectly informs the social media generation that something is up with those drugs. There's a lot of activity on social media where people say they're having a great result from their combination of drugs, and there's another, I guess you could say, type of activity where people are warning them that that's the drugs go bad and then they get into trouble. So there is, I think, quite a battle on social media, but nobody knows what to believe. And I think we have to plan an informational campaign really carefully so that we put this in the context of improving improving patient safety, and but also get the message across that individually people really need to think twice about going on a psychotropic, because it could be a long-term commitment and with no easy out. Anyway, that's my thinking about it, but let's talk further about this, because I think that you have some really good ideas about how to use social media. So does anybody else want to pitch in here? No?
I have one more quick thing just about an avenue of change. We're trying to target VA a little bit because the Department of Veterans Affairs has their own research and development arm. And it seems likely that if we could get in there with informed consent, there is a piece of legislation happening right now, and we're doing conferences. So we're going to be in Boston next week, and Bob Whitaker flies out for that. Kim Witzak, me, and this other person that was harmed. So we're trying to throw a series of conferences. The next one will be in DC in March. So we're trying to get into the VA somehow, because that could trickle down to the civilian side if we could get that. So that's one more avenue from the US side.
I think that, Angie, you and I talked about this. I think that the formally proposing a deprescribing program for veterans would be a really good idea. I think that's another direction that PDC could take that would be informative for everybody. Now, Ann Guy needs to leave, so I want to thank her, and thanks, Ann. We'll definitely be talking more with Ann, and I hope that we can hear more about her work in the UK.
Thanks very much, and I look forward to hearing what you've agreed to take forward. But thanks very much, all.
Okay, thank you, Anne. So it seems as though we're moving towards closing here. Is that right? Anybody else want to add to the conversation? Okay, so it seems as though there's a lot of concern about, let's say, the idea of the risk, which is going against the system, and that's perfectly understandable because, there's a lot of, I guess you could say, barriers in place to challenge medical authority. I'm hoping that the PDC can become authoritative enough to present an alternative that the medical professionals will respect, or at least, it might soften their preconceptions a little bit. So I would like to, one of the I think I mentioned before that PDC is a grassroots effort, in that we're hoping that our members would form project teams to work on different issues and probably produce publications and guidelines. And I ask that if you are interested in doing this, please contact me. I'm at adelef@deprescribing.org. I'm going to follow up this meeting with an email, which will have all the links and the email address in it. So, but I would really, there's people here have wonderful ideas. It's been a pleasure to meet you. and I would love it if we could work together on our common interests. Now, as I said earlier, this meeting has been recorded, and that would be for internal use. Also, for the people who reserved but could not attend, they'll be able to view the video so that they can see the discussion. I think that there's a lot of interesting material in this discussion, and I think that therapists expressing this dilemma, it's an ethical or a moral dilemma out of concern for their clients, but being unable to communicate to the rest of the care team, which would be the prescribers, is really a very significant factor that medical professionals really should know about. I think that there are many concerned medical professionals, but the avenues of communication really have never been established. I've been talked a lot about, but the avenues of communication between the rest of the care team and the medical professionals really have not been established in the United States anyway. Okay, well, I want to thank everyone for being here and contributing, and I'm really very I'm really touched about the show of interest in what we're doing, and I'm hoping that we can get together again.